you? It's Ryan here. Welcome to our 98th Mnemonic in the awesome discipline of internal medicine. I bring warm greetings in the precious name of my Lord and Savior Jesus. Today, it's my pleasure to be discussing systemic lupus erythematosus and the diagnostic criteria for this as per the ACR-EULAR guideline. But first, some quick jokes. I was trying to get a hold of some butterfly jokes in keeping with lupus. All I could find was caterpillar jokes. So ever wondered what a caterpillar is afraid of? A dog-a-pillar. And once a preschool teacher was reviewing some work with her students in class, and she asked them, "What does the bee give us?" "Honey," say the kids. "And what does the caterpillar give us?" she asks. "Silk," say the kids. "And what does the cow give us?" she asks. "Homework." Okay, guys, so in the last couple of videos, we were covering some wonderful prayers by the Apostle Paul for the New Testament saints. And he records for us our third prayer in the book of Philippians chapter 1, verse 9 through 11, when he says, "And this is my prayer, that your love may abound more and more in knowledge and depth of insight, so that you may be able to discern what is best, and may be pure and blameless until the day of Christ, filled with the fruit of righteousness that comes through Jesus Christ, to the glory and praise of God." Amen. So guys, let's get going. What is SLE, systemic lupus erythematosus? Well, it is an autoimmune disorder characterized by antibodies to nuclear and cytoplasmic antigens, multisystemic inflammation, protein clinical manifestations, and runs a relapsing and remitting course. Now, more than 90% of cases of SLE occur in women, frequently starting at childbearing age. What's interesting is that the word lupus is actually derived from the Latin word, which actually means wolf, and is attributed to the 13th century physician Rogerius, who used it to describe the facial erosions that were reminiscent of a wolf's bite. There you go. Okay, so now according to the 2019 ACR-EULAR guideline, right, there's diagnostic criteria for the diagnosis of lupus. So the entry criterion is that the patient must have anti-nuclear antibodies at a titer of greater than equal to 1:80 on Hep2 cells or an equivalent positive test. If absent, this does not classify as SLE, but if present, we need to apply additive criteria, and that the patient must have at least one clinical criterion, all right, and greater than equal to 10 points. Now, the holistic criteria is too large to pin down on this board of mine, so I'm just going to mention it, and then we're going to get into our mnemonic for today, right? So there's two domains. There's the clinical domain, and then there's the immunological domain. So by definition, the patient has to have at least one clinical criterion. And the clinical domains includes constitutional issues like fever, which scores you 2 points. Under hematological, we have leukopenia, which scores you 3 points, thrombocytopenia, 4 points, autoimmune hemolysis, which scores you 4 points. Under neuropsychiatric, we have delirium, which scores you 2 points, psychosis, 3 points, and seizure, 5 points. Under skin or mucocutaneous, we speak to non-scarring alopecia, which scores you 2 points, oral ulcers scores 2 points, subacute cutaneous or discoid lupus scores 4 points, acute cutaneous lupus 6 points. Serosal involvement, if the patient has a pleural or pericardial effusion, that scores 5 points, and acute pericarditis scores 6 points. Musculoskeletal, if there's joint involvement in the way of arthritis, scores you 6 points. Renal involvement, if there's proteinuria greater than 0.5 grams per 24 hours or above 0.05 millimole per mole on urine PCR, that scores you 4 points. If you've got renal biopsy classes 2 or 5 lupus nephritis, that's 8 points. If the renal biopsy shows class 3 or 4 lupus nephritis, that scores you 10 points. Then on the immunological domain, we have antiphospholipid antibodies. So if you have anticardiolipid antibodies positive or anti-beta-2-glycoprotein 1 antibodies positive or lupus anticoagulant positive, which scores you 2 points. In terms of complement, if you've got a low C3 or a low C4, that scores you 3 points. However, if you have a low C3 and a low C4, that scores you 4 points. And then you look at the SLE-specific antibodies. If you've got an anti-double-stranded DNA antibody or anti-Smith antibody, that scores you 6 points. Right, but in terms of our mnemonic as an aid memoir for the features of lupus, we look at 4 rashes. So the 4 rashes actually speaks to, firstly, 4, rashes speak to the malar rash, the discoid rash, the oral ulcers, which are usually painless, and photosensitivity. All right. But remember that acute cutaneous lupus usually manifests as the so-called butterfly rash, which occurs, on the face, right? But it spares nasolabial folds. All right. And remember that we also get the subacute form, in which we have the annular lesions and the styriform plaques, and the chronic form where we're looking at the discoid lesions. And you can also get lupus tinnitus and chilblain lupus, etc. Right. In terms of renal involvement, we mentioned that we have proteinuria greater than 0.5 grams per day, or more than 3 plus protein, or greater than 0.05 millimole per mole on urine protein creatinine ratio, or you may have cellular cast. But we'll talk a little bit more about lupus nephritis later on. Arthritis, we speak to involvement of more than 2 peripheral joints, and it's classically non-erosive. And the prototype of this is what we call Jacuzzi arthropathy, which looks like rheumatoid arthritis, except that there's no joint deformities. All right, so it's completely reducible. Then we speak to serositis, which involves pruritus and pericarditis, hematological involvement in the way of autoimmune hemolytic anemia, leukopenia below 4 times 10 to the 9 per liter, lymphopenia below 1.5 times 10 to the 9 per liter, and thrombocytopenia below 100 times 10 to the 9 per liter. E speaks to excitation and the way of CNS involvement with seizures and or psychosis. And serology we spoke about with your anti-nuclear factor, your anti-double-stranded DNA, anti-Smith, anti-phospholipid antibodies, and a false positive VDRL. So guys, just to get into a little bit more detail with the clinical features of lupus, joint symptoms include a symmetric non-erosive polyarthritis with joint pain, swelling, redness, and morning stiffness, generally lasting more than an hour, and dysfunction. On the hands, we look at Jacuzzi arthritis, like we mentioned, which is, and remember, joint deformities here are unusual, as we mentioned, and the fingers and wrists may be involved. In the legs, the knees are the most common joints involved, and don't forget avascular necrosis of the hip, shoulder, and knee, which may be affected. Extra-articular manifestations in the way of pulmonary involvement, right? So in pulmonary involvement, you can have pruritus in some 50%, pulmonary hypertension, pulmonary embolus, shrinking lung syndrome, which manifests with dyspnea, pruritic chest pain, progressive reduction in lung volumes, and elevated diaphragms. Cardiac involvement, you may have pericarditis, myocarditis, and endocarditis. Endocarditis in the way of what we term Liebman-Sachs endocarditis. A nice way to remember that is SLE causes LSE, which is systemic lupus erythematosus causes Liebman-Sachs endocarditis, right? Also known as merantic endocarditis. Now, these vegetations are not bacterial; they are just, thrombi, which embolize off from the heart into the periphery. Renal involvement, we speak to proteinuria or active sediment and glomerulonephritis, like we mentioned. So we know that there are different classes histologically on renal biopsy. So class 1 speaks to normal or minimal mesangial lupus nephritis, and these patients are often asymptomatic. Then class 2 is what we refer to as mesangial proliferative, where you get mild hemoproteinuria. And class 3 is a focal proliferative form, in which manifests with nephritic syndrome or proteinuria. Class 4 is diffuse proliferative form, which manifests with nephritic syndrome or nephrotic syndrome. Class 5 is membranous glomerulonephritis, in which you have predominantly nephrotic syndrome. And class 6 is advanced glomerulosclerosis, which presents with uremia and often renal impairment. So the severity is that class 6 is obviously the most severe, followed by class 4, class 3, then class 5, then class 2, then class 1. And you want to consider aggressive treatment specifically for classes 3 and 4. Okay. GI involvement in SLE, we speak to mesenteric thrombosis and vasculitis, transaminitis and hepatitis. Corticosteroids as well could increase your risk of peptic ulcer disease. Hematological, we spoke about already when we said there's anemia of chronic disease, autoimmune hemolysis, lymphopenia, and thrombocytopenia. CNS involvement, especially in the way of aseptic meningitis, transverse myelitis, stroke, seizures, organic brain syndrome, psychosis, depression, peripheral neuropathy. All right, so guys, just in terms of your serology in lupus, the ANA, which is the anti-nuclear antibody or the anti-nuclear factor, is relatively sensitive, above 99% sensitive. But the anti-double-stranded DNA, that is the one that's very specific, as well as the anti-Smith, which is very specific. You also want to screen for Sjogren's syndrome with the anti-Rho and anti-La antibody. Check for the anti U1 RMP if there's a mixed connective tissue disease element and antiphospholipid antibody syndrome. That has a sensitivity for some 40%. Also, you want to ask the patient about constitutional symptoms in the way of fatigue, fever, and you feel for lymph nodes. Ask about weight loss, myalgia. In terms of lupus exacerbations, right, these patients typically present with fatigue, arthritis, flaring of their mucocutaneous lesions, flaring of their renal involvement, neurological and/or skin involvement. Now, individual patients usually have a fixed pattern of presentation. Precipitants for a lupus flare include, UV exposure, medication non-adherence, infection, and pregnancy. Always consider other causes such as infection, medication side effects, that are steroids, and embolism. All right. So in terms of your workup for someone that you feel may have lupus, blood test to do is your full blood count with the differential, urea electrolytes, ESR, CRP. So those are your inflammatory markers. Do an anti-nuclear factor, anti-double-stranded DNA, and a complement levels C3 and C4. On the urine, you want to do urinalysis and the urine protein creatinine ratio. Special tests you can do in an inflammatory workup with extractable nuclear antigens, which is anti-Smith, which is very specific, anti-Rho and La, especially in pregnancy, because these are associated with neonatal lupus and congenital complete heart block. Do your antiphospholipid antibodies in the way of anticardiolipin, anti-beta-glycoprotein, and lupus anticoagulant, and you may want to do cryoglobulins, right? If the patient manifests with signs and symptoms suggestive of vasculitis. Infectious workup, you can do serologies for parvovirus, hepatitis B, C, Epstein-Barr, and CMV. And of course, if there's a synovial effusion, you want to tap that and send it off for a cell count with culture and crystals. All right. So just in general, guys, how do you manage lupus? So symptom control, if it's cutaneous lupus, you give the patient sunscreen, and hydroxychloroquine is the way to go. For arthritis, we can use non-steroidals. You can use hydroxychloroquine, steroids, methotrexate even. For nephritis and neuritis in general, we use, there's induction therapy and there's maintenance therapy. So for induction, we can use steroids, or we can use MMF or cyclophosphamide, and usually we maintain them on MMF. For serositis, we use non-steroidals and steroids. For thrombocytopenia, we opt for steroids, IVIG, and then of course, if it's non-responsive, then rituximab, splenectomy, and you want to avoid exogenous estrogen. So guys, there you have it. The aid memoir for the clinical features of lupus for rashes. God bless you.